Your last blood test came back normal. Your doctor looked at the numbers, nodded, and said everything looks fine. Maybe they printed the report. Maybe they just called with the all clear. Either way, the message was the same. Normal, fine, nothing to worry about. And you believe them. Because why wouldn't you? They are the doctor. The numbers are in the normal range. The system says you are okay. But here is what nobody told you. Inside that normal blood test, inside the column of numbers that all fall within the printed reference range, there is one number that has been sending you a message for 3, possibly 4, possibly 5 years. A message that your doctor's training taught them to ignore until that number crosses a specific threshold. A message that, once you know how to read it, changes everything about how you understand your kidney health. And the window to act on that message, the window where intervention produces the most dramatic, meaningful, measurable improvement in kidney function, that window is open right now, while the number still looks normal. I am Dr. Amelia Carter. I work at the intersection of functional medicine and vascular biomechanics. I study how the body's filtration and circulatory systems age at the cellular level. And more importantly, how to read the signals that the standard medical system is trained to overlook. Today, I am going to teach you how to read your own blood test in a way that your doctor almost certainly has not taught you. I am going to show you one specific number, a number hiding in plain sight on every standard blood panel. And I am going to show you exactly what it means when that number moves, even when it moves within the so-called normal range. This is not about alternative medicine. This is not about distrust of your physician. This is about understanding the difference between a snapshot and a trend, between a threshold and a trajectory, between waiting until something is wrong and recognizing the early signal that something is changing. Before I go any further, let me say clearly what I always say. I am a doctor. I am not your doctor. Nothing in this video replaces the guidance of your own physician. What I am giving you today is the scientific and clinical understanding to have a more informed, more specific, more productive conversation with your doctor about your kidney health. Use this video to prepare. Then take what you learn here into your next appointment now. Let me tell you about Margaret. Margaret was 71 years old, a retired school teacher from a small town in North Carolina. She had taught 4th grade for 34 years. The kind of teacher whose students came back decades later to tell her she had changed their lives. When Margaret retired, she did everything right. She walked every morning. She watched her diet. She took her blood pressure medication faithfully. She went to every annual physical. She had her blood drawn every year without fail. And every year, her doctor looked at her results and said the same thing. Everything is normal, Margaret. You are doing great. For 7 years, Margaret's creatinine, a number on her standard blood panel, looked like this. Year 1, 0.82, Year 2, 0.87, Year 3, 0.91, Year 4, 0.95, Year 5, 0.99, Year 6, 1.03, Year 7, 1.08. Every single one of those numbers falls within the standard laboratory reference range for a woman her age. Every single one would print on a blood report with no flag, no asterisk, no alert. Every single one would prompt a doctor trained in threshold-based medicine to say, normal, everything looks fine. What those 7 numbers actually show, when you look at them not as individual snapshots but as a trajectory, is a kidney filtration system losing roughly 8% of its functional capacity every 2 years. A slow, measurable, consistent decline that had been documented in her medical records for 7 consecutive years without anyone connecting the dots. By year 7, Margaret's kidney function had declined by enough that a functional medicine physician reviewing her full trajectory immediately recognized what was happening, not a dramatic crisis, not an emergency, a quiet, linear, predictable erosion that had been hiding in plain sight on her annual blood tests. And here is the part that matters most. At year 3, when Margaret's creatinine was 0.91, the intervention window was wide open. Dietary changes, blood pressure optimization, hydration strategy, specific nutritional support, removal of a common over-the-counter pain reliever she had been taking for her knees. These were all available, all evidence-based, and all capable of slowing or halting the trajectory she was on. By year 7, some of those interventions were still possible, but the window was narrower. The damage that had accumulated over those 4 additional years of unrecognized decline was structural and not entirely reversible. 7 years, 7 normal blood tests, 7 missed opportunities. That is what this video is about. Let me now teach you the science, because you cannot use this information until you understand it. And once you understand it, you will never look at a blood test the same way again. Your kidneys contain approximately 1 million tiny filtering units called nephrons. Each nephron is an intricate, self-contained filtration system, a coiled capillary network called the glomerulus that filters blood at high precision, connected to a tubular system that reabsorbs what the body needs and allows waste to pass into urine. 1 million of them, working in parallel, around the clock, every day of your life. Every minute, your kidneys filter approximately 1.3 liters of blood. In a 24-hour period, they process roughly 200 liters of fluid, recovering the vast majority of it and excreting a concentrated stream of waste. This process, this extraordinary, relentless, precision engineering of biological filtration, is what keeps your blood chemistry stable, your blood pressure regulated, your bones mineralizing properly, and your red blood cell production functioning. And it happens silently, without sensation, without feedback, without any alarm system that tells you when the capacity is beginning to erode. Now, creatinine is a waste product. It is generated continuously by your muscles as a byproduct of normal muscle energy metabolism, specifically from the breakdown of a compound called phosphocreatine. Every time your muscles contract, every step you take, every time you lift your fork, every time your heart beats, a small, predictable, consistent amount of creatinine is produced. This creatinine enters the bloodstream. It circulates. And because creatinine is a small molecule that is neither reabsorbed nor secreted in significant amounts by the kidney tubules, it is filtered out of the blood by the glomeruli at a rate that is directly proportional to how well those glomeruli are working. Here is the crucial point. If your muscle mass stays relatively stable, which it does in most adults, particularly in the absence of dramatic weight changes, your daily creatinine production stays relatively stable. You produce roughly the same amount every day. Therefore, if your blood creatinine level rises over time, there is only one primary explanation. The glomeruli are filtering it out less efficiently. The filtration capacity has decreased. A rising creatinine level, even within the normal range, is a direct quantitative signal of declining glomerular filtration. It is the kidney's own measurement of its own declining capacity, hiding in plain sight on your blood test, waiting for someone to read it as a trend rather than a threshold. The standard laboratory reference range for creatinine is approximately 0.6 to 1.2 milligrams per deciliter for women and 0.7 to 1.3 for men, with slight variations between laboratories. These ranges were established from population studies. They represent the range within which the majority of people fall. But here is the profound flaw in how threshold-based medicine uses this range. A creatinine of 0.82 and a creatinine of 1.18 both fall within the normal range. A physician trained to flag numbers outside the reference range will treat both numbers identically. Normal, no action required. But those two numbers represent dramatically different levels of kidney function, and if your creatinine has moved from 0.82 to 1.18 over 8 years, that movement represents a clinically meaningful loss of filtration capacity, regardless of the fact that both endpoints fall within the printed normal range. The reference range tells you where a number sits relative to a population at a single moment in time. It tells you nothing about where your number has been. It tells you nothing about where your number is going. It tells you nothing about the rate of change. It tells you nothing about the trajectory. And trajectory is everything. Let me introduce you to a concept that some physicians use but that almost never gets communicated to patients. It is called the creatinine slope. And understanding it is the difference between catching kidney decline at year 3 and catching it at year 7. The creatinine slope is simply the rate at which your creatinine level changes over time. A flat slope, 0.85 one year, 0.86 the next, 0.84 the year after, indicates stable kidney function. The number bounces slightly due to hydration, diet, and laboratory variation, but the trajectory over multiple years is essentially horizontal. A rising slope, consistent year-over-year increases, even small ones, indicates progressive decline. The rate of rise tells you approximately how fast function is being lost. Research published in the American Journal of Kidney Diseases found that a consistent annual increase in creatinine of just 0.1 milligrams per deciliter, 1/10 of 1 point, was associated with a significantly elevated risk of reaching end-stage kidney disease within 10 years, even when absolute creatinine values remained within the normal range throughout the observation period. 1/10 of 1 point. Per year, still normal, still getting a clean bill of health at every appointment. The kidney research community has a name for what happens when creatinine rises consistently within the normal range before crossing the clinical threshold. They call it the creatinine creep. And the 3 to 5 years of creatinine creep before the number crosses into the flagged zone represents the single most important and most consistently missed intervention window in all of nephrology. Now, I want to give you the tools to identify this pattern in your own records. Because you have the data, it is sitting in your patient portal or in the paper records in a folder somewhere or accessible from your physician's office. The numbers have been recorded every year. They have just never been looked at as a story. Here is how to read your own creatinine trend. Go back as far as your records allow. Pull every blood test result you have. Annual physicals, pre-surgery panels, cardiology checkups, anything that included a basic metabolic panel or a comprehensive metabolic panel. Creatinine will be listed on all of these. Write the numbers down in chronological order with the date next to each one. Now look at the sequence, not at whether any individual number is normal or abnormal. At the direction. At the consistency of movement. Is your creatinine sitting at essentially the same level year after year, bouncing within a narrow band of 0.05 to 0.10 points? That is a flat slope. That is stable. Or is your creatinine rising 0.82, then 0.88, then 0.93, then 0.98, then 1.04, consistently in one direction year after year, even by small amounts? That is a rising slope. That is the creatinine creep. That is the signal. If you see a rising slope, the next number I want you to calculate is your eGFR, estimated glomerular filtration rate. This is the number that more directly translates creatinine into an estimate of actual kidney filtration capacity. Many laboratories now calculate and report eGFR automatically alongside creatinine. If yours does not, there are validated online calculators where you can enter your creatinine, age, sex, and race to generate the estimate. The eGFR categories used clinically are as follows. Above 90 is considered normal or high. 60 to 89 is mildly decreased. 45 to 59 is mildly to moderately decreased. 30 to 44 is moderately to severely decreased. Below 30 is severely decreased. Below 15 is kidney failure. Here is the thing most people do not know. You can have an eGFR that declines from 95 to 72 over 8 years, from normal to the mildly decreased category, and never receive a single alert from your standard blood test results, because 72 is still within the range that most laboratory reports treat as acceptable. But the trajectory from 95 to 72 over 8 years represents a loss of roughly 24% of estimated kidney filtration capacity. That is not nothing. That is a quarter of your kidney function, quietly eroded over nearly a decade, with every annual blood test returning a clean result. Now I want to address something that I know some of you are thinking. If creatinine rises as kidney function declines, does it also change for other reasons? Could a high creatinine just mean you ate a lot of meat yesterday or that you are dehydrated? Yes. Creatinine can be temporarily elevated by high protein intake, intense exercise, dehydration, and certain medications, including some common antibiotics and pain relievers. This is precisely why a single creatinine measurement in isolation is limited as a diagnostic tool. But a consistent, year-over-year rise across multiple measurements taken under routine, non-extreme conditions, your standard annual physical, not the day after running a marathon, is not explained by diet or hydration variation. The short-term fluctuations average out across years of measurements. What remains is the underlying trend. This is why I am asking you to look at years of data, not a single result. The noise in individual measurements resolves when you look at the pattern over time. And the pattern, if it is consistently rising, is telling you something real about your kidney function trajectory. Let me now walk you through the 6 most common drivers of creatinine creep in adults over 60. Understanding what is causing the trajectory gives you a roadmap for what to address. The first driver is chronic subclinical dehydration. This is the most common and the most underappreciated cause of gradually rising creatinine in older adults. And it is almost entirely correctable. Here is why it is so prevalent in seniors specifically. The thirst mechanism, the neurological signal that tells you that you need water, weakens with age. Research consistently shows that adults over 65 have a significantly blunted thirst response compared to younger adults. You can be meaningfully dehydrated without feeling thirsty. Your body has lost the early warning signal. Meanwhile, many seniors consciously or unconsciously reduce fluid intake to avoid nighttime bathroom trips, to avoid urgency in social situations, or simply out of habit. The result is a chronic state of mild dehydration that persists day after day, month after month. Reduced blood volume means reduced blood flow to the kidneys. Reduced blood flow to the kidneys means reduced filtration pressure. Reduced filtration pressure means reduced creatinine clearance. The creatinine that your muscles are producing at the same rate every day is being cleared more slowly because the kidneys are not receiving the blood flow they need to filter at capacity. Over months and years, chronic mild dehydration contributes measurably to rising creatinine even in kidneys that are otherwise healthy. The intervention is simple, not easy, because habits and thirst signals are hard to override, but simple. Adequate, consistent fluid intake distributed throughout the day, not concentrated in the morning or evening, is one of the most powerful and most accessible tools for supporting kidney filtration in older adults. A practical guideline that works well for seniors. Drink a full glass of water with every meal and one between each meal. 6 to 8 glasses distributed across the day, not as a bolus in the morning, distributed. The second driver is chronic NSAID use. We have touched on this in previous discussions, but in the context of creatinine creep, it deserves detailed attention. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, and related medications work by blocking the production of prostaglandins throughout the body. Prostaglandins are inflammatory signaling molecules, and blocking them reduces pain and inflammation effectively. But prostaglandins also serve a critical, non-inflammatory function inside the kidney. They regulate the tone of the afferent arterioles, the tiny blood vessels that feed blood into each glomerulus. Specifically, when blood pressure or blood volume drops, prostaglandins dilate these arterioles to maintain adequate blood flow to the filtration units. When NSAIDs block prostaglandin production, this protective dilation mechanism is suppressed. The afferent arterioles constrict. Blood flow to the glomeruli decreases. Filtration pressure drops. Creatinine clearance declines. In a young, healthy kidney, this is a temporary and largely reversible effect that resolves when the NSAID is metabolized. But in an older kidney that has already lost nephron mass, that is already filtering at reduced capacity, that is already managing with less reserve, the NSAID-induced reduction in blood flow is not trivial. And in someone taking NSAIDs daily or near daily for chronic pain, which is extremely common in adults over 60 managing arthritis, back pain, or joint conditions, this suppression of renal blood flow is occurring continuously. Day after day of slightly reduced glomerular blood flow, month after month, year after year, the creatinine creeps upward. And because the pain is real, and because the NSAIDs provide genuine relief, and because they are available without a prescription, and because no one has connected their habitual use to the slowly rising number on the blood panel, the exposure continues. If you are using NSAIDs regularly and your creatinine has been rising, this connection deserves a direct, specific conversation with your physician. There are alternative approaches to chronic pain management: physical therapy, topical anti-inflammatory preparations that minimize systemic absorption, other medication classes that do not suppress renal prostaglandins. The third driver is blood pressure that is controlled on the cuff, but not optimized for the kidney. This is perhaps the most nuanced of the 6 drivers, and the most important for seniors who are already on blood pressure medication. Your blood pressure medication may be doing exactly what it was prescribed to do, lowering the pressure measured in your arm. But the pressure inside the glomerulus, the filtration pressure that determines how efficiently each nephron can do its job, is determined not just by systemic blood pressure, but by the tone of 2 sets of tiny arterioles: the afferent arterioles feeding the glomerulus and the efferent arterioles leaving it. Different blood pressure medications affect these arteriolar systems very differently. ACE inhibitors and ARBs, medications like lisinopril, ramipril, losartan, and valsartan, are specifically nephroprotective. They preferentially dilate the efferent arteriole, which reduces the pressure differential across the glomerular membrane in a way that reduces mechanical stress on the filtration architecture. For this reason, ACE inhibitors and ARBs are considered the preferred class of blood pressure medication in patients with any degree of kidney dysfunction. Calcium channel blockers preferentially dilate the afferent arteriole. This increases glomerular filtration pressure, which can appear as an improvement in eGFR in the short term, but chronically elevated glomerular pressure, glomerular hypertension, damages the delicate filtration membrane over time through a process called hyperfiltration injury. If your blood pressure is being managed with medications that do not include an ACE inhibitor or ARB, and if your creatinine has been rising, this is a specific conversation worth having with your physician. Not about whether your blood pressure is controlled, about whether the specific medications being used for that control are optimizing or inadvertently compromising your kidney filtration architecture. The 4th driver is protein in the urine that is not being measured. Proteinuria, the presence of protein in the urine, is one of the earliest and most sensitive indicators of glomerular damage. Healthy glomeruli retain large proteins like albumin in the blood and allow only tiny molecules through. When the filtration membrane is damaged, protein begins to leak into the urine. Standard blood tests do not measure proteinuria. A basic metabolic panel measures creatinine in the blood. It does not look at the urine at all. Urine albumin to creatinine ratio, a simple, inexpensive urine test, can detect protein leakage at levels far too small to cause visible changes in the urine years before the damage is reflected in rising blood creatinine. Research consistently shows that microalbuminuria, very small amounts of albumin in the urine, precedes rising creatinine by years as a marker of early glomerular damage. If your creatinine has been rising and you have not had a urine albumin to creatinine ratio measured recently, you are missing a crucial piece of the picture. Ask for it by name at your next appointment. The 5th driver is blood sugar dysregulation, particularly the range between normal fasting glucose and diagnosed diabetes. This is a space that does not get nearly enough attention in standard clinical care. The category of impaired fasting glucose, fasting blood sugar between 100 and 125 milligrams per deciliter, is a well-documented independent risk factor for declining kidney function, even in the absence of a formal diabetes diagnosis. Here is the mechanism. Elevated glucose in the blood, even at levels below the diabetic threshold, undergoes a process called non-enzymatic glycation. Glucose molecules attach to proteins, including the structural proteins that make up the glomerular filtration membrane and alter their physical properties. The membrane becomes stiffer, less selective, less efficient. Additionally, elevated glucose triggers the production of advanced glycation end products, AGs, which stimulate inflammatory pathways inside the kidney and contribute to progressive structural damage to the nephrons. If your fasting glucose has been creeping upward, even staying within the normal or pre-diabetic range, and your creatinine has also been rising, these two trends may not be coincidental. They may be two manifestations of the same underlying metabolic process affecting your kidney architecture. The sixth driver is something almost nobody discusses with their patients, and it connects back to what we discussed in a previous masterclass. It is nocturnal hypertension. The standard blood pressure measurements that drive clinical decisions, the readings taken at your doctor's office almost always during daytime hours, tell you nothing about what your blood pressure does between midnight and 6 in the morning, and as we have established, for a significant proportion of adults over 65, blood pressure does not dip during sleep the way it should. The glomeruli, those 1 million delicate filtration units, are subjected to whatever pressure the systemic circulation delivers. During the night, in a healthy cardiovascular system, the pressure drops. The glomeruli get a recovery window. The mechanical stress on the filtration membranes is relieved for several hours. In a non-dipper, someone whose blood pressure stays elevated through the night, the glomeruli receive continuous daytime level pressure, 24 hours a day, without recovery. The cumulative mechanical stress on the filtration membrane is substantially higher than what a standard office blood pressure reading would suggest. Research has shown that nocturnal hypertension is a stronger predictor of kidney function decline than daytime blood pressure in older adults. And because it is invisible to the standard office visit, which measures blood pressure during the day, it can be driving creatinine creep for years while every office visit returns a controlled reading. If your blood pressure appears well controlled at your appointments but your creatinine has been rising, nocturnal hypertension is a specific and important possibility to investigate. A 24-hour ambulatory blood pressure monitor, a small device worn for a full day and night that records pressure at regular intervals, is the only way to see what your blood pressure is doing while you sleep. This test is readily available, non-invasive, and covered by most insurance when there is a clinical indication. Rising creatinine in a patient with apparently controlled blood pressure is a clinical indication. Now, I want to bring all of this together into a specific, concrete action plan, because information without action is just anxiety. And the whole purpose of everything I have taught you today is to translate it into something you can do tomorrow morning. Here is your 5-step kidney protection action plan. Step 1. Pull your blood test records for the last 5 to 10 years and find your creatinine value from each one. Write them in chronological order. Look for the slope. Is it flat? Is it rising? If it is rising, by how much per year on average? Write that number down. That is the data point you are going to bring to your doctor. Step 2. Ask your doctor for a urine albumin to creatinine ratio test at your next appointment. This is a simple urine test. It is inexpensive. It is the earliest available marker of glomerular damage. If you have never had one, you are missing a crucial piece of your kidney health picture. If your doctor asks why, say, "My creatinine has been rising within the normal range, and I want to establish a baseline for early glomerular function assessment." Step 3. Ask for your eGFR to be calculated and recorded at every blood test going forward. Many labs calculate it automatically. If yours does not, ask for it specifically. Track it the same way you are tracking creatinine, as a trend, not a single snapshot. Step 4. Review your medication list specifically for NSAID use. If you are taking ibuprofen, naproxen, or related medications regularly, even at over-the-counter doses, tell your physician that you are concerned about the connection between regular NSAID use and declining renal prostaglandins. Ask about alternatives for chronic pain management that do not suppress kidney blood flow. Step 5. If your blood pressure is managed with medications that do not include an ACE inhibitor or an ARB, Ask your physician whether your current medication class is optimal for kidney protection given your creatinine trend. You are not asking them to change your medication. You are asking whether the current choice has been evaluated in the context of your kidney trajectory. And here are the exact words to say to your doctor when you walk in. Say this: Doctor, I have been tracking my creatinine values from my last several blood tests, and I have noticed a consistent upward trend even though each individual result falls within the normal range. I am concerned about the trajectory rather than any single number. I would like to discuss what might be driving this trend, whether a urine albumin to creatinine ratio test would be appropriate, and whether my current medication regimen is optimized for kidney protection given this trend. That statement does three things simultaneously. It shows your doctor that you have done meaningful, data-driven preparation. It introduces the concept of trend analysis rather than threshold assessment, and it invites a collaborative, evidence-based conversation rather than creating a confrontational dynamic. No physician who hears that statement should dismiss it. If they do, you have important information about whether that physician is engaging with your care at the level you deserve. Now, let me tell you what happened to Margaret. At year 7 of her creatinine creep, Margaret's granddaughter, a second-year medical student, came home for the holidays. Margaret mentioned almost casually that her doctor always said her blood tests were normal. Her granddaughter asked to see the reports. She laid them out on the kitchen table. 7 years of results. She found the creatinine column and wrote the numbers in a row. 0.82, 0.87, 0.91, 0.95, 0.99, 1.03, 1.08. She sat quietly for a moment. Then she said, "Grandma, these numbers are all normal, but they have been going in one direction for 7 years without stopping. That is not a normal pattern. That is a trend." Margaret had never heard the word creatinine explained to her before that moment. She had never understood what it measured. She had never been told that the direction of the number mattered as much as the number itself. Her granddaughter accompanied her to her next appointment. They brought the 7-year creatinine list. They asked for a urine albumin to creatinine ratio. They asked about her NSAID use. She had been taking ibuprofen every day for 2 years for knee arthritis without mentioning it to her doctor because she considered it a supplement, not a medication. They asked about nocturnal blood pressure because her morning headaches had been a quiet, ignored presence for 3 years. The urine test came back showing microalbuminuria, low-level protein leakage that had never been tested for. Her 24-hour blood pressure monitor showed her nighttime blood pressure was averaging 148/88, while her daytime office readings averaged 128/76. Her ibuprofen was stopped. Her physician switched her blood pressure medication to include an RB specifically for nephroprotection. She was referred to a nephrologist for co-management. She increased her fluid intake and distributed it throughout the day. She began a gentle walking program to support cardiovascular health without joint overload. Her creatinine at the next annual blood test, 1.04, down from 1.08, a small number, not dramatic, but a slope that had been consistently rising for 7 years had stopped rising. And in kidney medicine, stopping the slope is the win, because the nephrons you have are the nephrons you keep. Margaret cried at that appointment. Not from fear, from relief, from the feeling of having been seen, of having had a number that had been silently recorded for 7 consecutive years finally understood as the message it had always been. Her doctor, to his credit, looked at the trajectory on the page and said quietly, "I should have looked at this as a pattern years ago." He was right, and he was not a bad doctor. He was a good doctor practicing threshold-based medicine in a system that gave him 7 minutes per appointment and rewarded normal results with a clean bill of health. The system failed Margaret, not the physician. The system. And the way to protect yourself from a system that is not designed to catch what Margaret's numbers were showing is to understand your own data well enough to catch it yourself. You now have that understanding. Let me close with something I want you to carry with you from today. Your kidneys are the most silent major organs in your body. They do not ache when they are stressed. They do not send pain signals when nephrons are lost. They do not alert you when their filtration capacity is quietly declining. They simply keep working at 90%, then 80%, then 70%, without complaint and without warning until the reserve is gone and the symptoms finally appear. By the time chronic kidney disease produces clear symptoms, the fatigue that does not resolve, the swelling that does not go down, the foamy urine, the elevated creatinine that finally crosses the threshold and gets a flag on the lab report, a significant and irreversible portion of kidney function is typically already gone. The creatinine creep, the slow, consistent, within normal range rise that precedes the threshold crossing by 3 to 5 years, is the kidney's only early warning system. It is quiet, it is subtle. It requires looking at years of data as a story rather than a series of isolated snapshots, and it requires someone in the appointment room who knows to look for it. That person is now you. Go find your blood tests. Write down your creatinine values in order. Look at the slope. If it is rising, bring it to your doctor with the language I gave you. Ask for the urine albumin test. Ask about your medication classes. Ask about nocturnal blood pressure if your morning numbers suggest it. Do not wait for the flag. The flag means the window is closing. Act on the trend. The trend is the message. Your kidneys have been working for you every second of every day of your entire life, every breath, every meal, every night of sleep. They have filtered your blood millions of times without ever asking for anything in return. Today is the day you start reading what they have been quietly trying to tell you. I am Dr. Amelia Carter. Take care of your kidneys, take care of your body. I will see you in the next video.